Hello and welcome to this special interview. The National Health Insurance Policy kicks in this coming February. It's a long way where this is coming from. So much has been achieved in terms of this very important national health policy. What has been done so far? What is the National Health Insurance Policy? What are the benefits? What are the issues surrounding registration, accreditation? Yes, of course, the major issue surrounds the benefits. To give us a rundown of exactly where we're coming from, where we are, and where we are going is the Director General of the National Health Insurance Authority, James Kapesa. Welcome to this interview, Director General.
Thank you so much, Frank.
Tell us first the genesis of this very important national health insurance policy.
Frank, by 2012, the government had made a clear decision that we needed a system, a structure that pulls individual small units of resources together in a fund, get this fund and procure high quality health care services to cover all our citizens. By that time, a minuscule proportion of our people had some form of access to any meaningful healthcare service. Again, the government, through Vision 2030, had decided that for Zambia to attain middle income, middle status position, we needed to have a prosperous citizenry.
Right.
But embedded in the concept of prosperity is the concept of health. And so putting Vision 2030, speaking to prosperity and health, into how we can lift the mass of our people to access high impact, good quality health care, the National Health Insurance Scheme was birthed. It has gone through processes of consultation with key stakeholders like trade unions, government agencies, cooperating partners. It has had a full discussion around experts from the insurance industry, around actuarial experts who have come in to put together a package, a project that makes sure that we raise the number of people in the country from 4% who are currently accessing healthcare of one or the other to 100%. Secondly, the scheme also was designed to attempt to remove financial barriers to access to universal health. It also wanted to remove inefficiencies, to remove low service levels as a discouragement to people to get our health care services. Because of these three things, by 2018 April, His Excellency President Lungu had signed into law the National Health Insurance Bill. Frank, from April 2018 to April 2019, a lot of background work had started happening at the Ministry of Health by way of a working group under the auspices of the Healthcare Financing Department. Last year in March, the board was inaugurated and management, which I now head, was instituted to now move this long-awaited program from the paper, from the concept, from the drawing board, now to flesh and blood. And I can proudly announce to our viewers that in the last 6 to 7 months, the management team has broken a lot of ground. Our 7 key implementation milestones that moves this project from a concept on paper to something tangible have been all but achieved.
DG Kapesa, 4% accessing health care out of 17 million. That's a very unhealthy number. The factors behind that, and 2, what target is this scheme hoping to raise to in terms of a percentage?
The 4% speaks to the dysfunctional nature of the health system as we speak now, both provided by the public sector and the private sector. Dysfunctional in the sense that those numbers in themselves are not critical enough to allow the public to access this facility efficiently. It means that the prices of, for example, private healthcare deliveries are high because they are based on a very narrow population of people. Number two, it then means that the 96% of our people face what we call catastrophic health expenditure at the point of service delivery. What then the scheme does, it moves away from this tragedy, and I call it a tragedy, Frank, that only 4 out of 100 of our people can go home believing that if they have a health incident, they will be looked after. What happens to the 96%? And for the country to assume that that's normal, for the country and the leadership in the private sector to assume that that's sustainable is a tragedy. So the National Health Insurance Scheme, at its core, attempts to, one, remove catastrophic health expenditure from your pocket, which currently stands at about 28%.
Yeah.
Most of our people, Frank, have fallen into poverty. They have gone to borrow Shylock and Kaloba monies.
Yeah.
Not because they are consumption driven like we hear. 16% of those who have fallen into poverty, who have borrowed high cost exorbitant loans, did so because they needed to fund an emergency health expenditure, thereby pushing them into poverty. The scheme attempts to remove that barrier so that there is universal access to high quality healthcare.
Before we talk about what has been achieved in the last 7 months in terms of registration, in terms of accreditation, in terms of benefits, let's talk about the 1% that you are charging. How did you arrive, at this? And is this sufficient enough to ensure benefits?
The starting point, Frank, is to marry the 1%, which is the resources that I'm pulling into my fund called the National Health Insurance Fund. I would have wanted a higher contribution. Uganda, for example, is at legislative stage for a scheme of similar conception and constitution like us. They are 10%. Ghana has a higher contribution rate. And so then what I did is that I then needed to look at my 1%, and I'll talk about how the 1% comes in, and go and create a benefit package that is not 100%, that doesn't include every bell and whistle, but that matches my 1%. How did the 1% come into being? Frank, there used to be a voluntary medical scheme under the civil service. And in around 2012, 2013, government, through a collective agreement with many civil servant unions, decided that they needed 7 principles into their conditions of service. One of them was the health fund.
Right.
Over and above the health fund, there are things like funeral insurance. That's why you see that the civil servants have a funeral insurance. And during that bargaining, that collective bargaining, the civil service, by which time we are the biggest part of our target group, came up with the 1%. And when we were looped in to see how the 1% sat with our benefit package, our take as a working team by then was that this was a good point to start from. Is there a possibility that this could be adjusted? Our first port of call is to bring to the fund as many people as possible. The one 1.2 million formal employed Zambians is not enough. So is the 1% enough? Yes, it is enough. Why do I say so? Because I can bring on board sufficient number of contributors who can then be able to help me run the scheme solvently. Thirdly, I have a task as an authority to ensure that when that 100 kwacha you contribute comes into the pool, I look for alternative, viable, and safe ways of generating additional revenue that supports me. Because the ultimate purpose is that the scheme must have sufficient resources, sufficient monies to pay a hospital when they present a bill.
The million question: what are my benefits? What am I getting out of this scheme or from this scheme?
Very critical question, very important that the public understands the benefit package. Frank, the authority working with partners in the Ministry of Health, has taken a long time, a long process, a very exhaustive process of, number one, deciding what are the key conditions that afflict our people in terms of disease burden, in terms of mortalities. So we went around, invited experts, asked them these questions, looked at reports in the Ministry of Health, and isolated 10 causes of morbidity and mortality. These then informed the authority on what disease conditions we should put in the benefit package. We brought the experts who, again, costed the processes, who costed each drug. We also looked at the National Drug Formulary. What are the drug regimes that are approved and used in the country? Bringing all these various experts, consulting our partners, I can announce to the public that we now have a very comprehensive benefit package comprising of 167 individual conditions. Now, some of these include, number one, all your child and maternal health issues are covered. So if you are an expecting mother, you should not be scared of financial loss or paying huge amounts of money at the point of service, because if you contribute to the scheme, from the first day you go for your antenatal to the last day you discharged, up until our child is about 5, you are covered. Frank, we have also looked at covering internal medicine like malaria. It's fully covered. We have covered your outpatient visits. We have covered all your surgeries are covered. Blood is one of the most critical ingredients in service delivery across all our first level, second level, and third level hospitals. All blood products are covered. So this is a list of conditions, Frank, which we have put into what we are calling a benefit package, which we have published and is available at our website. But how is it a benefit and not a list of conditions? The benefits attached to this list of conditions is that, number one, you have access to all our network of accredited facilities, meaning that if you are Lusaka based and you happen to be visiting Kasama or Mongu and you fall sick, with our card, you have access to initially 127 facilities. Frank, you have access to some of the best experts around. It's not like we will be asking you to go to a hospital which has more experts, which is at a higher level. Because you are a member of the scheme, you have access up to the highest level of our medical care without incurring additional costs. Frank, you have access to pharmacies. Just in case in your locality there is, heaven forbid, stock out for drugs, we will have a network of pharmacies that are going to be accredited. So you have access to that. And like I said, you have access to unlimited high-quality healthcare because you are a member of the scheme.
Deji, you've articulated the benefits, very well. What about the person who's in the rural area? We're saying, I already have benefits because I'm accessing a service from primary, health centers where, the access is free. That's number one. Number two, what about those people who already got insurance, schemes who are already enjoying, benefits? How do you convince, these two?
For my brother who is in the rural area, I agree with you. It's important to emphasize that primary health care is free, provided for by the government. But this scheme, Frank, is also pinnacled on solidarity, meaning that the person who is in the rural areas in some way or the other is in solidarity with someone else who could be their brother in town. Some of our colleagues in the rural areas have the children in schools and universities here. There is a student benefit package.
Yeah.
Some of them have relatives who are in areas where we have accredited facilities. Their contributions are providing cover for those. But important of all is that should that person in the rural area require referral services to a district hospital, should they require ambulance services to a provincial hospital, they will move to the district hospital, produce the card, and they will not be required to pay anything.
And those who have already got insurance schemes elsewhere?
For those who've got insurance schemes, two things happen. The first thing is that we're encouraging them to still contribute to the National Health Insurance Authority because it's law. Number two, they can still keep their private insurance and use the National Health Insurance space and card to bring in more members of their extended family, of their household, onto the scheme. Because most private insurance schemes have limits on how many people you can put on the scheme, how many times you visit the hospital, how many conditions are acceptable. The National Health Insurance Scheme gives you almost a carte blanche. Secondly, it's also important for employers to know, and I know that some employers have started moving away from the private insurance. We want to encourage you that see the National Health Insurance Scheme as your basic insurance cover for your employees, and then use private health insurance as additional and complementary to some of the benefits that you're unable to get under that scheme.
Brilliant. All right. Having said that, now you've been working on this for years, and especially the last 7 critical months. Could you report to the nation the progress in terms of registration and in terms of accreditation?
In terms of registration, the registration department using our online portal has registered over 320,000 members, 320,000 contributing members across all our membership spectrums, from public sector, private sector, and informal sector. We are pushing, Frank, to ensure that our targets are met in this year. In terms of accreditation, I can confirm and report to the nation that phase 1 of the accreditation process has completed successfully, with 127 public institutions comprising government hospitals, mission hospitals accredited. And as I speak, there's a team from NHIMA in all the provincial centers who are training hospital management to be ready to receive the public once we open our doors. We are also giving them accreditation certificates. So the first phase is done. The public may wish to know that phase 2 will now encompass private sector, private facilities, and commences in April 2020. Frank, it's also important to report to the nation that the Secretariat of the Authority is now fully functional. Fantastic. With all the departments fully staffed. They can visit us for any comments. We have also made progress in ensuring that operating systems, accounting systems, insurance systems, claims systems, we've made tremendous progress to ensure that these processes are at a near ready position before the public comes to the facility.
Just 3 questions, before we wind up, this interview, DG Kapesa. One, like you have said, you've, clarified the benefits, and you really made it look very, very attractive, and indeed it's attractive.
Thank you.
Yeah. Having said that, why then have some quarters, a minimum of that, being, against this national scheme?
Frank, the public ought to know that in the first place, this is a new concept. It's a new thing, and it's human nature to have to ask questions about something that has not been done before. So we give our stakeholders who have questions a benefit of doubt. Secondly, in a project of this nature, there will always be a level of questions, there will be a level of doubt. What we decided to do is that we decided to identify key stakeholders who had a different view of how we were implementing the process, and we decided to go and start engaging them, asking them, what are the key issues on the table? Is it the benefit package? Is it the accreditation process? Are you not comfortable that we start with public facilities? No, we are not comfortable. My nearest facility is a private hospital. Then says, fine. Come April, there will be an opportunity for private sectors to qualify. Is it about the way we have gone about collecting contributions before we start to provide benefits? We've gone back to them, engaged them, and explained, for example, why we had to start and provide a 4 months period in which we can start to. And as you engage partners, as you listen to them, as you concede in some of their issues, you start to create consensus. And as I speak to you, we are not 100% on the same page, but the levels of differences, the number of areas where we had views of different perspectives is narrowing down. I don't, as DG, expect that I will have everyone on board, but I can assure the nation that we are listening and we are implementing any issues that are of value to the scheme that are brought about by every stakeholder.
Finally, DG Kapesa, the implementation date. 2, accountability. 3, can this scheme be sustained endlessly?
The implementation date. Ideally, as at 1st of October, I should have had, in theory, everyone register. For those that registered and paid in October, the card printing process is almost complete. They will receive cards and they will be ready to go to our facility. So what do they expect to find at an accredited facility? They will expect at the gate or at the fence of UTH a poster announcing that this is a NHIMA accredited facility. When they go to the outpatient department, which is where they start the process from, they will be welcomed by a NHIMA billboard announcing that you have entered a NHIMA accredited environment. When they go into the OPDs, they will then meet our officers. There will be a NHIMA specific desk which will receive them and ask them a number of questions that identifies them as a member, and the process smoothly starts from there. That's how ready we are. Those are our levels of readiness. Can we sustain the scheme, Frank? NHIMA will be run as a business. It will take the best from the private sector in terms of adherence to process and protocol. It will also take the acumens and accountabilities that you find in the private sector in terms of adherence to deadline reporting, in terms of thrift and frugality in using resources. It will also be zero tolerant to non-performance. These things put together means that the fund will have an opportunity to grow beyond the initial principle that I receive. It means that my attention to cost details, my attention to quality in the hospitals, my attention to wastage will be heightened at all levels. These things put together means that we will create enough scope, we will create enough space for the funds in the authority to go a mile, 10 miles further. In that way, we are assuring the nation that the fund will be solvent, and if we have a solvent fund, it means the scheme is sustainable. Frank, the dream is that let our children come and find something which they can proudly mention our names. Let them come and say, oh, they did this in very difficult circumstances. Let us bequeath for once, as a country, something that our children can be proud of.
DG Kapesa, always wealthy to talk to you. Good luck. Somebody has to do a very important national assignment, and we wish you all the success.
Thank you so much.
Thank you. That was the Director General of the National Health Insurance Authority. The National Health Insurance Authority, facilitating the national health policy. And remember, a healthy nation is a wealthy nation. Thank you for watching. Have a healthy day.